Good evening, everybody, and thank you for coming to our webinar on lower back pain this evening. My name's Tara Belcher. I'm a GP at Portmill Surgery and I'm the Clinical Director of Hitchin and Whitwell Primary Care Network, which is bringing this event to you this evening. Thanks again for coming and welcome to Ed, who is our Senior Physiotherapist, who's going to talk to us this evening about low back pain. But before I hand over to Ed, just wanted to let you know that the PCN has got a website and that this webinar and all of the other education events that we've had will be recorded and available for you on the website. We've also got a new Instagram account, which hopefully you've seen on the slide that's on the screen there, and that will be used to share information and updates with all of our patients. Also, for anybody who doesn't know already, we do run an enhanced access service, so you're able to visit Portmill Surgery, but that's available for patients at any of the Hitchin and Whitwell practices, 6:30 to 8 p.m. every evening, Monday to Friday, and also 9 to 5 on a Saturday. We have a whole range of services with GPs, nurses, pharmacists, etc. there. And my final little nugget is please don't forget to use the NHS app. It has loads of useful information on it, and you can easily order your repeat prescriptions through that app on your phone. So enough from me. Well, I'm going to hand over to Ed, who's going to tell you all about low back pain, which is obviously a really common and painful condition, and it can really have an awful impact on people's lives. There will be an opportunity at the end of the presentation to answer questions. So if you've got any questions, please do pop them in the Q&A, and Dion and myself will be looking at those, and we'll be asking Ed your questions at the end of the event. So thanks once again, and over to Ed.
Good evening, everyone. I'm assuming you can hear me okay and see me.
I can hear you fine. Can't see your slides yet, Ed, but
I'm gonna be sharing any second now. So just let me know when you can see them up. Play settings, swap. Perfect. Can you see them?
Absolutely.
Perfect. Well, I can't see any faces or anyone actually. And if you do have any questions, I think Tara mentioned that. Yeah, you can put them in the Q&A section, and we've put some good time away in the end to go through them. So I'll get started. Where is my next slide? There you go. So I'll start with just a little bit of myself. As Tara mentioned, I'm one of the senior sort of physiotherapist that works for the Hitchin and Whitwell PCN. I'm mostly in Portmill. Actually, some of you might have met me. My role is it's called a first contact practitioner or first contact physiotherapist, and it's to help GPs with diagnosis and management of musculoskeletal conditions. I also do have a sort of a varied role where I am on my other days. I also work as part of the musculoskeletal team, and that's sort of helping to manage people through the orthopedic pathway. And I work with a spinal team quite a lot, so have a bit of background in this, and hopefully a relatively good understanding. The aim of today is to just look at a few. It's to really look at the basic aspect of causes of back pains, what might contribute towards them, things you can do to help manage, roles of things like medications. We get very commonly asked about things like investigations and imaging, and what to expect from healthcare professionals. So I can't obviously hear people, but often we go, oh, has anyone heard of these? But these are sort of the most common terms: sciatica, arthritis, spondylosis. There's all sorts. As healthcare professionals, we tend to group them up and just call them mechanical lower back pain or non-specific lower back pain. And there's a reason for it, which we'll come to later. But essentially, a lot of these terms mean a similar, same thing. It's back pain being caused by mechanics, and there's different aspects of them, of course. So here's some of the things that can cause back pain and contribute towards it. So muscles, joints, discs, nerves, ligaments. There's also obviously a whole aspect of non-mechanical back pain, things like kidneys and heart can all refer, prostate can all refer, but we're not going to necessarily cover that today. But these are for mechanical back pain. These are things that can So this is where we sort of get into it a little bit, and I think back pain in itself gets quite a bad rep. I think it's often maybe a little bit catastrophized, and a lot of what we do day to day is actually a lot of reassurance to people. And I put in this big letters, and it's a whole movement we now see in sort of the musculoskeletal world. Is pain doesn't always mean harm. We assume that if we have pain, it's something abnormal and very problematic. And the way we tend to look at it, you can have structural changes, so fractures, there's a slip of vertebra and very problematic discs and severe degenerative changes, etc. But that actually accounts for infections and whatnot. That accounts for a very small proportion of sort of population back pain. And I would say really serious conditions, it's less than 2% when you look at the larger statistics. And those symptoms are often worsening, marked limitation range of movement. Most often, because such a confined space, you'll start to get neurological symptoms, sciatica, loss of sensation in the legs, etc., etc. What we see mostly day to day, and I'd say 95 to 90% of people, is irritation of those structures. And this is where there's lots of things that contribute towards, and that might be weakness, tightness, stress. There's lots of psychosocial factors, etc., which we'll talk about a little bit. But a lot of things that can contribute towards lower back pain aren't necessarily harmful, and this is where obviously it's very useful to get an assessment, etc. But often individuals think that they're on this side of the spectrum, whereas the statistical likelihood is that most of us are on this side of the spectrum. So contributing factors, these are some of the things that can not necessarily cause pain, because pain, lower back pain, is highly complicated, and there's a variety of all these things that will add up. Social should have been highlighted. But the terminology used in sort of today's practice is the biopsychosocial model, and there's biological aspects, there's psychological, and there's social aspects. So biological is everything to do with your body. So how strong and fit you are has obviously a bearing on it. Your weight, diet, age. So with age, things do change. Anatomy, genetics can contribute. Trauma. So if you've had physical, even psychological trauma, sometimes can contribute. Sleep quality. And things like medication. So essentially, how we rest our body and what we put in our body, which goes back to weight, diet, etc. Psychological is perception, so fear avoidance. I'll come back to this aspect of it, and I'll explain that a little bit about stress and anxiety. Not often do individuals put the two together, but stress and anxiety have a very, very high correlation with lower back pain and how it contributes. And there's a variety of ways it can contribute. But just the other day, I saw someone who was I think it's about 6 or 8 months ago for his back pain. He came in for something else to do with his shoulder, and I just asked, because I saw in the notes that we saw him not so long. I said, "Oh, how's your back doing?" He said, "Actually, since the work project finished that was stressing me out, kind of disappeared. I wasn't sat at my desk stressed for 12 hours a day." So it's things like that, and it doesn't mean it's that simple, but these things can contribute. And perceptions in terms of psychological, and I put bend your knees, not your back. We often perceive that we have to protect our back, and we call it, there's a concept called fear of avoidance, where due to pain we become fearful of movement, and we develop avoidance behaviors. This advice of bend your knees, not your back, and protect your back is now out of date by good 5 to 10, if not more, years. And hopefully it's not being practiced too much in health and safety talks, etc. But I think I've seen something recently that encouraged it. But nevertheless, essentially, initially, it's a very good bit of advice. Protect your back. Don't use it. It's good, and then everyone starts to be protective of their back. Unfortunately, what then happens is once you develop this perception that your back needs protecting, you stop using it. And as we all know, if you stop using it, you lose it. So any bend and any use of your back becomes painful. In short term, you see this great benefit of, well, I haven't used my back, it doesn't hurt, to long term, actually does, and our perception of how we should behave around our back is a really great factor, really. And then social aspects of it, so lifestyle, work, family, you know, how much we expose ourselves to, much we sit, how much we do, how much stress we get, how much time we have to ourselves, etc. Some of those, so those are the sort of overview of contributing factors. I said a lot of these things will overlap, and some, you know, some people it might be mostly their weight that's contributing. Some might be more stress. Some might be because they've had major trauma. Some might be because they just don't exercise enough. But it's an overlap of all of them, really. So these I just alluded to it a few slides ago, but these are the really things that you should be worrying about. Things that are pain that's often worse at night, and getting some night pain isn't unusual, especially if you're turning, etc. But if you're getting pain that doesn't matter what you do and it's worse at night, it's not letting you sleep, you should always, especially if it's lasting over days and you know, weeks, it's always good to speak to someone. It's not unusual, but it can be a concerning feature. Leg weakness, progressive loss of sensation. So if you're losing sensation, your foot, your calf area, you're getting cramps, you're getting weakness, and it's progressively getting worse. Again, that could be a neurological deficit and compression of nerves, etc. That needs looking at. Anything that affects your health, sweating, fevers, weight loss, anything that controls your bladder or bowel. So if you're getting lots of back pain, and often people would, and again, there's nuance to this. If you've got very bad back pain and you struggle to go to the toilet and push, that's one thing. But if you're losing bowel control and sensation, that's something very, very different. Shortness of breath, chest pains, and pains that don't change with movements. Again, hopefully most people would think to contact someone if they're getting severe shortness of breath and chest pains and back pain, to speak to someone. But if you haven't thought of that, I would speak to someone urgently. And pain that doesn't change a movement. So if it doesn't matter what you lift, how you bend, where you sleep, what you do, your pain never changes. Again, that's always worth discussing with someone in terms of diagnosis, excluding anything sinister, really. Management techniques. So I put one of the key aspects is working out what contributes towards your back pain. Managing back pain, especially pain that you've had for quite a while or that continuously reoccurs, requires an in-depth analysis of your lifestyle, essentially, and what may contribute. And some things may be very obvious, and lots of things are much less obvious. What we can often tell people is what things contribute. It's often down to the individuals to try to sort of assess their lifestyle, because as clinicians, we don't necessarily live and observe you day to day. It's rarely as simple as one tight muscle, one stiff joint, and it's all going to go away, especially if you're getting reoccurrent symptoms. And you've got to look at lifestyle, weight, exercise levels, sleep, stress, your general fitness, and it goes back to the biopsychosocial model, really. Management techniques. So exercise, obviously, we all know exercise can be good, and that can be general. I think we'll look at it in the next slide, but it could be very, very general exercise depending on your starting point. So if you're very sedentary, you probably just need to get going. Going down to, if you exercise a lot, it might be that you have a very particular weakness, and that has to be very, very specific. Your weight, sleep pattern. So people who have irregular sleep patterns and sleep very well, it's how our body recovers. Those who don't sleep very well don't necessarily look at there's something called sleep hygiene, which is about clearing up your routine, developing routine, etc. Those who don't sleep very well, unfortunately, are much more prone to injury, because essentially that's how our body recovers. Heat, cold, really useful. Often people ask which one's better. It's generally a preference, and the general science for pain is that sensation of heat or cold travels to our brain quicker than pain. So if you put something very cold on an area of pain, your body will feel the sensation of cold or hot, or temperature-based stuff. So any of those can be really good. Stress anxiety management, so your coping mechanisms, lifestyle, meditation, diet, all those things. Medications, we'll talk about that a little bit later, but thought pattern, so am I avoiding or changing behavior? Am I being overprotective? Massage, manipulations, and things like acupuncture as well, which we'll sort of allude to. So exercise self-management, look at your starting point. Often, if you're not someone that exercises a lot, just start somewhere. Go out for a walk, for a brisk walk to get yourself out of breath. Do a low-level yoga class. Just do something that you enjoy. And it's very important to progress slowly. One of the main contributors towards injury or re-injury is that people tend to think they can do more than they can actually do. A lot of theoretical science about treatment of patients is actually very simple. Is look at what their starting level is and then progress them very slowly. We try to teach this, but often as individuals we do forget this, and we try probably a little bit too much. And consider other aspects of your lifestyle. Again, diet, weight, sleep, all the simple things. And it's just a little note towards the end about behavior change. If you're someone that's struggling to find exercise that that works, or you do long term and you tried a bit of exercise, maybe it worked, but you didn't enjoy Pilates or something. For long term change and improvement in health, it's good to find something that works for you and that you enjoy. If you do things that you have to do, often I think the statistical science is that within 4 to 6 weeks we tend to quit those things. So we do them a little bit and then we'll stop. Whereas if it's something you enjoy doing, you'll often carry on. So it's just a little tip. Manipulation and massage, really helpful if done well. Can help to build confidence, pain, and it just improve muscle viability, etc. It should be used as a short-term reliever to give someone confidence and get them back up to where they were. Especially for chronic pain, it's actually in the national guidelines now that that we shouldn't necessarily be using things like acupuncture and massage and manipulation. And the science is that although we feel like lots is being done, when you really look at the science and you break down the cellular activity, etc., hands-on treatment doesn't actually do a huge amount. It can help to change the tissue for hours to maybe days, but it restores itself. So if you've got a chronic condition, be careful of being convinced that it's lots of manual therapy that you need, is what I would say. But it has its place and it can be really good. Unfortunately, on the national health, because manipulation, something in massage, etc., has such a short-term carryover, often the national health doesn't offer ongoing massages, manipulations, but what we can do is sometimes use your therapist to say, you know what, there's an acute problem. What we'll do is do a little bit of massage manipulation, and that will get you going, and then you need to start exercising, etc. Same with acupuncture. Medication, so just like I was talking about, just manipulation, massage, short-term pain relief to allow you to return to activity. Often, one of the sort of, I don't know if I would agree, but often people say, I don't want to take medication. I don't like taking medication. I don't want to just hide away from the problem. And that's assuming that you have a structural problem which you can damage. Actually, if your pain is much more structural irritability, lowering the pain can help you to increase your activity levels and get you back to normal. And taking it regularly for a few days, up to a week or so, is really good. As the pain goes on for longer, and for someone who's suffering from chronic pain, stronger medications, things like gabapentins and opioids, even the and this is where we know that unfortunately it's not a good idea to use them. Even the pharmaceutical companies admit that they should merit caution, and now the national guidelines suggest that we should be avoiding using them. And it's all to do with your body does adapt and your nervous system adapts to the medication. And essentially what happens is initially you get this great spike of improvement, and then over time that declines, and you see over 3, 5, 10 years that people's dosages increase, but their level of pain also increases, which obviously doesn't match. And that's where we try to discourage people from long-term medications. And then surgery, injections. So this is where if you're part of that, unfortunately part of that 5 or 10% of individuals who may need surgical interventions, there's surgeries, there's injections, and that's what you're referred for. Back pain surgeries are very rare and actually not really done. There's a few structural reasons where you might have back surgery, but that's very, very, very rare. Most of back surgery is done to relieve neurological pain, and that's your true leg pain, true sciatica, which is pain going down essentially below the knee, causing sensory disturbance, pins and needles, numbness, etc. Imaging, this is another thing that we get asked for quite a lot. Really good and useful for telling us what structures are gone potentially wrong, etc., and how we might manage someone who needs non-conservative management, i.e. surgery and injections. They don't tell us exactly what's causing the pain. There's lots of reports, and sometimes people say, oh, you've got a bit of degenerative disc, or you've got facet joint atrophy, etc. There's a really good website called the British Association of Spinal Surgeons, and that's in my notes, and it's in the reference list as well, so you can go to that afterwards, but you can have a little read around it. And I think the quote they use is it's only good at identifying 10 to 15% of what's actually wrong, and that's only if they have a very obvious infection or fracture, etc. Everything else is a bit of guesswork, and I'll show you why that is. This is a really famous study done on 3,100 patients, there you go, who've never ever had back pain. And essentially what you see is they recorded these things that they found on the scans. So signal loss, which weakness signal, height changes, degenerative discs, disc bulges, protrusions, anal fissure, which is a small tear of the disc, degenerative change around facets, spondylolisthesis, where the vertebra slips one on top of the other. And essentially what you see is by the age of 30, you're more likely to have disc changes than not. You essentially flip a coin, and on a scan, pretty much everyone's would say by the time you're 40, 50, you're going to have something on a scan. It'd be almost unlikely that you didn't really. And that's because, and the way I explain it to people is that our skin, our hair, everything changes with time, and so do our joints, etc. That's not abnormal. Some of it might contribute to your pain, but it's not always an abnormality. And the reason we don't tend to just scan people and tell them that you've got a degenerative disc, because that's relatively normal abnormality. That's like saying someone who's in their 50s that they might have a couple of grey hairs. You might, unfortunately. And we tend to concentrate on, what are your contributing factors? What can you do to help? How can we help? Those kind of things, and obviously excluding serious pathology. So our role as healthcare professionals, in primary care, so myself and Dr. Gotcha worked, our primary role is to exclude pathology and help to identify the potential causes, and provide some information advice. That's what we're there for. So if you're ever worried, etc., come in and don't be afraid to ask. We don't necessarily offer lots of treatment. Secondary care, which is where you get referred for actual physiotherapy, specialist services for imaging, like I was saying, MSK services, where you get referred for imaging and injections and things like that. They can offer guided exercise, help to reassure you, get you back into activity, or even go down the sort of surgical routes and injections, whatever else it might be. Summary: lower back pain's a really complicated issue. It affects most of us, and being frank, most people experience some sort of pain around their spine during their lifestyle. Although some of us may have pain because of a serious pathology, most of us don't have that. And just be careful not to fall into seeing especially private world sometimes catastrophizing clinicians, etc., who say this is bad or it's very bad symptoms here, or the scan suggested X, Y, Z. Consider the factors. Look at your exercise levels. If you work a lot and you stand all day, do you ever rest well? Do you sleep well? Are you eating well? Are you stressed? Are you very anxious? Do you avoid movements? Do you have little confidence in your back? Those kind of thing. Imaging is to help diagnose true structural pathology and serious pathology. It very rarely offers simple answers because the solution's never really simple. Here's some useful links, and again, that will be shared on the website. But my particular one I really like is if you just type in Google lower back pain exercises. I think it's 4 or 5 video of basic exercises where you stretch, move your back, and it's a really good starting point to get yourself stretching. There's also a Pilates video, so for those of you who might enjoy or like Pilates or yoga, there's back pain yoga and Pilates videos where you can slowly follow. And I always say start very slowly, incremental, and progress yourself. Spinal surgeons, again, if you just Google British Association of Spinal Surgeons BASE, they have a whole patient information leaflet, and they talk about specific exercises and scans and imaging and things to worry about. And there's also a website, so a company, that organization I work for, as you can see in the background, Pure Physiotherapy. It has a self-help tool. So if you just type in Pure Physiotherapy, in the website it says self-help tool. You can click on it, and it has loads of exercise and things. Perfect. Any questions? I imagine there might be a few.
So much. Thank you so much, Ed. That was really, really interesting. And actually, I learned a lot from it. And it made me realise that as a GP, I think I'm probably quite guilty of not always using that biopsychosocial model. When thinking about back pain, we do just tend to think, oh, it's probably muscular. And maybe think about people's weight, but certainly not think about maybe things like sleep and those sorts of important things. And I would say I absolutely agree with you on the pain relief with the non-structural changes. I think we often start with and sort of go up the pain ladder, and then when it's obvious that it's chronic, sometimes people are then a bit reluctant to try reducing those painkillers back down. But there is actually a big local campaign at the moment to try and reduce addictive pain medication and think about other ways that we might manage chronic pain. Actually, I don't know, Dion, whether you can see something I can't, but I can't see any questions at all.
No, I can't see any questions coming through. The option is definitely enabled.
Oh, good.
Yes,
I've explained it so well.
I've got a question. I've
Go
got
on,
a question in. So no, not here we are. So we've got a question in here. If back pain is making your sleep difficult, I mean, I'm assuming that we've taken the advice that we're not. We've spoken to the GP and we don't think this is a red flag symptom. But if back pain is making your sleep difficult, what can you do about it?
That's a very good point. And I guess sometimes, obviously, again, you'd have to look at your differentiating factors. There is sometimes an oversimplification of things of, oh, just change the mattress. Again, the science around that is very, if you look at any research around mattress suggestions, funnily enough, is done by the mattress companies. Very small populations, about 10 people who slept better. So you could try changing of mattresses, of course, but also it could be just a vicious cycle of where, unfortunately, if you again look at diet, sleep, how much you exercise, what your routine is what your stress levels are like. Again, stress can really affect sleep, which then keeps you awake, which then means you notice pain more. When you sleep less, your pain perception is worse, your exercise tolerance is lower, your diet's probably likely to be poorer, which makes everything, it just becomes this vicious cycle of pain. The advice would be is look at the factors that may be contributing that we mentioned before, again, the biopsychosocial model, and then try to work out what you can do in the day to change. And the likelihood is those things will start to improve your sleep. There's also, I mentioned it earlier, alluded to, you can Google it. There's something called sleep hygiene, which is it's a concept, I think, built on a book that was written. I'm very, very iffy about the facts of this. I don't know if you know much more about this, Tara, but essentially it's to do with the fact that there's very few cases of any of insomnia in the Amish community and communities that don't have access to technology. And essentially it's to do with introduction of blue light to your brain, to where if you're exposed to lots of television and noises and lights, your brain gets overactive and that doesn't allow you to sleep. And so sleep hygiene is hygiene, cleaning up your routine before you go to bed. It was a big thing a few years ago. We often talk about it in the MSK pathway when we sit down with people and really look at their lifestyle. Again, it's a massive part of chronic pain management, but that's something you could look at.
Yes, we do still talk about sleep hygiene. I didn't know that was where it came from. We also actually, as a PCN, we also do have access to an online tool called Sleep Station. So although that isn't necessarily going to fix your back pain, as Ed says, if actually sleep issues might be contributing to your back pain, it's worth having a look at Sleep Station. Literally, if you just Google Sleep Station, it will take you through, and there's some cognitive behavioural techniques to help you with insomnia, which is really helpful and has been proven to be effective. That's something that not everybody has access to, but as I say, our PCN does fund that so that any of the patients in Hitchin and Whitwell can use it. So I've got a couple of other questions in the chat. So the next one is, what can you do for, if anything, what can you do for spinal stenosis?
It depends on the severity of it, I guess. So that's for those stenotic change is essentially a degenerative change that happens to your spine. Again, depending on usage, lifestyle, age, there's genetic predispositions. The thing with it is keep moving. The more you move, the better. Now, obviously, it's a self-limiting thing, but this is what tends to happen. I alluded to it. It's fear avoidance. If you have back pain and you move less, you start to atrophy and essentially gain weight and lose muscle, which gives your spine even less support, which hurts more, and you move less, and it becomes this vicious cycle. So it's moving as much as you can. Now, that doesn't mean keep pushing into your pain. And this is another concept. If anyone here's seen me, I always talk about is it's a progression, and doing too much is no good, but resting too much isn't good either. It's just a progression of exercises. There's lots of stuff, I think, even if you go on the Pure Physiotherapy website, I think there's a tab for spinal stenosis. But essentially, it's keep walking, keep moving, and keep exercising. Things like swimming can be quite helpful as well.
So I'm so sorry, I've got somebody who's said about the video camera, so I can see we've turned the slides off. This is the first time we've used I think it's called the Town Hall version of Teams, and we just, there we go. Ed is now on your screen.
Hello.
Fantastic. So now you can
Sorry
see
about the
him.
look.
Wonderful. So that's great. So we've got another question, which is, it says, I've had back pain for years. I was doing physio, which helped for a while, but I took a month out from training and it's gone back to how it was. Still doing the physio. My physio says just to keep doing the same exercises I've been doing for a year. What would you suggest?
Oh, that's good. So very, very good question. I guess first of all, do you enjoy those exercise, and how much of other activity and exercise doing? I alluded to sort of being specific and generic. There isn't one exercise that is better than another. There's so much science on this now, where there's lots of good exercises. There's not many bad ones. Some might hurt you a bit more, and that's a decision for you to make. But actually, I would maybe try to include a bit of variety. If you're doing lots of stretches, maybe do a bit more strengthening. If you're doing lots of strengthening, maybe do a little bit more stretching. Also consider some of those other factors like stress, sleep, diet, just general lifestyle things. As I said, there was someone who it was just a lovely story, because I've done lots of stuff around psychosocial stuff, and just even in the triage service and the spinal triage service, we see so much of this. As I said, someone was saying we tried everything and he had MRIs and nothing was really structurally shown, and actually it was his work that was contributing to the stress. And as soon as the project finished, back pain finished. So it's looking at a lot of the other factors, perhaps.
Thanks, Ed. And now we've got a question which says, what are your views on the usefulness of medical cannabis or CBD for chronic back pain? I know it would be private, it isn't NHS, but is it an alternative to taking tablets for a prolonged period of time?
I guess it's the same concept as any medication. Obviously, I don't know about the long-term usage side effects, and I guess again depends on dosage. I don't think it's a good thing to use any substance for long periods for that. I think if you use it to help your pain to improve your lifestyle, I'm sure that there could be some use. If you're using it as a singular thing and then you're quite sedentary, you eat poorly, you have poor sleeping patterns, you have no management techniques of stress and anxiety, that isn't going to be the answer. It's kind of what I was finishing up with earlier, where I was saying that back pain is very complicated, and if you're looking for a singular answer, from my experience, it's very, very rarely there. Most people, well, some people improve with one massage or one exercise or one pill, but most of us don't. So if you're having to rely on something like that, use it to help you, but also look at all these other things. Don't just rely on the whatever, name the drug.
Super. That probably slightly answers this next question. And if you're happy to take it, Ed, that's fine. But if you'd rather I answer it, that's also fine. So the question is, I've been taking naproxen for about 8 years. This definitely helps to ease my chronic back pain, but is there any risk of other health risks from the long-term use of naproxen?
I'll say first of all, yes, there are. There's lots of I'm sure Tara could allude to, but taking any medication has it, and with naproxen in particular, I had I'll let you, Tara, finish up on the sort of more exact science, but it was a really, really good talk we had from I think he was a pharmacist. I can't remember what his title was, but he was a pharmacist. He worked with sports medicine quite a lot, and there was a lot of research that came out of sports medicine. Athletes use medication quite a lot, and naproxen in particular came up. And the way he described it, I really liked it. It's like when we use our body, we develop calluses, and we get a little bit tougher and stronger. Anti-inflammatories, because they remove all the some of the bad inflammatory cells, but also a lot of the good ones, we fail to condition. And over a long period of time, what they saw is people were much more prone to injury because they took things like naproxen. Although it helped short term, long term, it made them essentially weaker because they never developed the conditioning. But I'm sure Tara could also talk about the gastrointestinal and all these other issues.
Yeah, I think for me with naproxen, some of it's to do with the age of the person taking it, but anybody who's taking it. So naproxen is one of the family of non-steroidal anti-inflammatory drugs in the same family as ibuprofen, and any of them, and aspirin actually, and those medications can irritate the stomach. They can sometimes cause stomach ulcers and bleeding. And certainly in the long term, if you are needing to take it, then we sometimes give people stomach protection medication as well. I mean, obviously Ed's saying about long-term medication, we're talking about pain relief here not being ideal. Some of you may be on high blood pressure medication. We would absolutely advocate you carry on taking that.
Yeah, fair enough.
But when we're talking about trying to limit the medication use for pain, naproxen, as I say, it can irritate the tummy. It can also sometimes cause problems with the kidneys, and if you've got high blood pressure, we don't always recommend using it, although it can be safe in some circumstances. Short-term use certainly, and some asthmatic patients don't get on very well with naproxen. So yes, it's not an ideal medication. Paracetamol is generally far safer if you're going to use something longer term. So we've then got a question. Can you offer some advice about posture when pulling loads? I have to pull a dinghy ashore, lifting loads from ground level, driving position. I took a lifting course at work some years ago, and the main takeaway was not to twist the spine while carrying a heavy load. Any thoughts on that? So that's really interesting, because I think we've all done those health and safety courses, as you alluded to, where you bend your knees, do this and that.
Bend your back, actually, so first of all, yeah, exactly what Tara said. We're really trying to get away. That's highly outdated point of view now. Actually, if you need to pull things like dinghies or lift from low ground, you need to practice lifting and doing those things. I don't know, again, age and gender of this person, but in the gym, if you have access to it, or any weight, you need to be lifting and practicing to lift them from the ground, so you're strong in those positions. If you avoid those positions and you don't know how to lift those things, you're just going to be weak and prone to injury. Not twisting your spine again, has a very lovely outcome for short term relief, because you don't use your spine, so it can't physically hurt. But long term, it's just going to be weak. And it doesn't mean you go out and pull a dinghy and start twisting again if you're not used to it, but actually building up and trialing it and getting strong is the answer. I would very much suggest not avoiding things. And again, if you just bend your knees and never your back, you're going to get weak back, but also at some point you probably come and see me for your knees.
Thanks, Ed. Is it still recommended that actually strong core helps with your back?
Yeah, I think again the research is very varied around that, because there was there used to be a movement where just strengthen your core and you'll be fine, but that has to have a context to it. So if you're very good at holding a plank, but you've never practiced lifting a weight off the floor, you'll be very good at the plank, but as soon as it comes to lifting a box off the floor, your back's going to hurt because it's not used to it. So yes, it really helps, but there's much more context to it. If you want to be strong at something, you've got to practice it and do those things. If you avoid them and then try to do them, it will naturally hurt because your body's not used to it, really.
Absolutely. I think we could say that for any muscle, couldn't you? I went and did a gym class the other day and ended up with painful biceps because I haven't done those sort of curls very much before.
Yes. Sorry, and can I just add a point to that? We had a really recent interesting conversation with some of the pain sounds good, but if you hurt your bicep, you wouldn't like exactly what you said. You'd be quite relaxed about it probably. If you pulled your back, most people would catastrophize that a lot more, and that's based on our perceptions and things like that. If you hurt your back and you get lots of neurological symptoms, worry. If you've got some aches and it's gone to a bit of a spasm, it's harder to move for a few days, it's unlikely that it's something seriously wrong. It could be, and if it doesn't go away, come see us, but treat it like any other joint. Don't overthink that it's just because it's your back it's worse.
That's really good advice, I think, there, Ed. Another question. What are the recommendations for spinal curves combined with spinal stenosis? Balance is severely affected. I'm not sure I quite understand that. I don't know whether is that an exercise, a spinal curve? Or do we mean like the lordosis?
Yeah, and the kyphosis. I guess I will answer some of the stuff around the... I would actually come in, if your balance is severely affected, I would probably come in and get an assessment for your neurology. That's the first thing. And there's lots of things that come to mind with that. But if that's affected, come in and get assessment if you haven't done so already and you need it. In terms of curvature, this is another thing that often... it's a bit of a pseudoscience if I'm being brutally honest, but just because based on what's out there in terms of research. But we're all slightly different. We all have different curvatures in our backs. There are abnormalities, and you can have scoliosis where your spine goes sideways, but we are all different. There isn't one normal way of being. There's an oversimplification of it in the world of where, you should sit properly with your lordosis, etc., this way or that way. And actually, for some people, it's impossible. Like Afro-Caribbean people have a much larger lordosis. They can't sit physically like me because I have a much lesser lordosis because my genetics from Eastern Europe. I don't have the same type of spine. It's different. We can't be like... it's just different. So when people say, you should just sit like this, for some people be really comfortable, for others uncomfortable. Hopefully that covers some of the spinal curvature conversation.
Thanks, Ed. And then we've got a question which, and it's interesting because you had touched on what you might find on an MRI scan. And this person says, my MRI, and I know we're not going to be able to give individual advice here because we don't know the whole story, but the question is, I've had an MRI and I've been told I've got degenerative disc disease. Will I have this forever? And the pain has been bad, particularly since October. It's the longest stint I've had so far. Normally it only lasts a few months. Have we got any advice there?
Oh, yeah, really good question. So degenerative disc disease is my favorite overused scary term, which often doesn't mean a huge amount. Just like I showed on the slide, the likelihood of you having a degenerative disc disease where your disc gets slightly smaller is essentially, you're more likely to have it than not by the age of 30, 35. Even in the age of 20, you have a 30, 40% chance of having it. That doesn't mean you have a significant structural deformity. Now, you might do, I don't necessarily know your symptoms, but if you take that diagnosis, which sounds really scary because it's disease, etc. If you take that out of it and go back to the normal mechanical back pain and look at the factors of your exercises, sleep, how much you move, do you protect your back? Often people who've been diagnosed with something that sounds as scary as that, very protective of their back. So you go back to the behavioral science, which is, am I very fearful to and avoidant of moving my back? Often what happens is people are told this severe diagnosis, which essentially just means they have not relatively normal changes, depending plus minus neurology, which might not be, but let's just say you don't have many neurological symptoms like sciatica. It just means you have normal back pain. Your back is relatively normal for potentially your age group, and actually you need to, instead of concentrating on this disease, it's much better you look forward at concentrating on what can you change in your lifestyle, strengthen your back, trust it, and it will probably be much better.
Thanks, Ed. Thinking about exercises, I do quite like this question because I remember I've had patients before who've said, I can't possibly exercise because I can't afford a gym membership. But you really don't need to go to the gym. And this is a really good question. I can't bear the thought of a gym. And I can't say I necessarily blame this person. Sometimes it's quite a scary environment, actually walking into a weights room full of testosterone and sweat. Can you do exercises that alleviate back pain without having to go to a gym or create one in your own home?
Yes, of course, yes. First of all, can I really agree to exercise and activity is a spectrum of whatever. Some people like cycling and hate the gym. Other people like running. I'm not one of those people, but some people love swimming. Other people hate swimming. So do what you enjoy and makes you happy, and you definitely don't have to go to the gym. A long brisk walk. Before I did this talk, I took the dog out for a walk. We call it the hill loop. It's a massive hill we have to go up. Took me out breath. That's my exercise done for the day. That's good enough for me, being for out of breath for half an hour. And you don't necessarily always have to, depends again on your level, but if you don't exercise very much, something like that will already have a pretty good benefit. You don't need to exercise for your back. Now, again, if you're already very fit and active and then you want to target, then you can do lots of stuff at home. The websites I showed you have lots of it. There's loads of resources. Said there are Pilates exercises. There's tons of stuff on YouTube. There's lots of free resources. This is the best time ever for exercise, if I'm honest, because there's just so much free stuff on the internet.
Absolutely, and we will have these slides available, which have got the website links on our website at the end of this as well. Or if you were to just look up Pure Physio, Ed's company's name is there behind you. They've got loads of resources, not just for backs, actually. They've got loads of really good resources for lots of different musculoskeletal problems, haven't you?
Yeah, so if you have any pains or aches, or you've been diagnosed something, you can look on, and it's a very simple website where you essentially just click on a diagnosis like knee pain, or I've got a bit of arthritis, click on it, and it gives you an explanation, all the latest research, and then at the end it gives you progressive exercise, so basic level, intermediate level, and the sort of more advanced level stuff, and then you can pick where you are. And again, what it highlights is bit of pain and bit of activity is good, lots of pain is bad. So just find your groove, find how much you can do, and do it.
Brilliant. And I think it's always useful to know that, because there are so many resources out there. Sometimes it's hard to know where to look and what to trust. And we'd be quite happy to say that's a good resource that you can use.
Hopefully, I think we're revamping some of it just because already some of the exercise may be a bit outdated. But I will say this, in terms of what's a good or a bad exercise, it's rare that you find something very bad. I mean, if something's telling you, to bounce on a trampoline at the age of 80 and do a backflip to stretch your back out, probably not that one. But often people get injured more because they do too much too quickly, not because the exercise is bad. And that's much more of an ego thing. Clicking on a beginner's class always hurts my feelings in yoga, but I can't do the advanced stuff because it hurts my back, funnily enough. But I'm like, I think I'm an advanced guy. I'm pretty fit. And then I pull my back, funnily enough.
Well, Ed, it's kind of good to hear that maybe sometimes you pull your back too.
I do hurt my back quite a lot doing silly things, yes. I did some patio work the other weekend, and I honestly couldn't work for 3 days. Couldn't walk for 3 days properly.
Oh dear. So we've got one last question, unless any more get added to the chat, which is about the spinal stenosis again. Just saying, are there any specific exercises that help spinal stenosis, or should this person just keep doing sort of flexibility work that they're already doing?
Yeah, you'd probably want to. The specific stuff would be based on an assessment that a clinician does. Stenosis usually gets worse when you're stood, so when you're in extension, and better when you're sitting. Too much sitting will mean that you're intolerant of extension, so practicing stuff into extension is usually really good, but that depends on tolerance and assessments and things like that. But I wouldn't necessarily dare to say, oh, just do this exercise and your stenosis will be better. Just keep active.
Super. So we've got a few minutes left, but I think that unless any more questions pop into the chat, what I would say is that don't forget, guys, that you can book directly with our physios. In fact, they would much prefer that you went first to them, because they are a first contact service rather than going via the GP. So if you speak to your reception team and you have a musculoskeletal problem, we've got a team of physios who'd be delighted to see you.
Yes, yeah, and we can help to exclude serious pathology as well. I think often people think, well, this might be a kidney problem. Actually, I think I might have actually come and spoken to Tara not so long ago about someone who I was like, this doesn't quite sound right. And then we can refer and do things, and we can help to refer you for scans and bloods and things like that if need be. So don't be afraid. And yeah, come in, have a chat, get some exercise and things, or some advice, some reassurance. Don't be afraid to ask, really. Would rather help people with these things.
Super. Thank you ever so much, Ed, for your time. I found that really interesting this evening, and I'm kind of feeling like I need to get lots of my colleagues to watch this back and take some information from that as well. I'm not sure whether we've got a way of sending out Dion feedback forms, because as I say, we haven't used this format before, so I don't know whether we've got people's email addresses.
I'm not 100% sure, but I was going to have a look tomorrow. So if I do have the email addresses, I will be sending out a feedback form.
Yeah, always useful to get feedback. We do. Yeah, good. Well, any feedback, constructive feedback. We do run these education webinars every month. We have a different topic. I believe we've got diabetes coming up, and HRT and menopause again. We are also we're planning to have something for our younger patients, hoping to encourage them into a career in healthcare. So we'll be doing that in the autumn, and we'll be keeping people updated with information on the website, through Instagram, and also you may get texts through from the surgery. We would love it if more people wanted to join our patient participation group, so that we can get feedback from you about the sorts of things you'd like to see us doing, and also if any of you are interested in perhaps volunteering to help out with things, that would be fabulous. And again, you can find out how to join the patient participation group on our website. So thank you once again, everybody, for coming this evening. And if we haven't got any other questions, I will let you all go 5 minutes early. Thanks, Ed.
Thank you, everyone. Bye-bye.
Bye.